So she, of course, we after the talk we can have a discussion together. So I'm going to talk about our journey basically in developing a COVID-19 test, and we started really as academics at the University of South Wales, and together with Emma and Ali, who is an electronic engineer, we was basically taken over our life the last more than a year now to do this. So I'm going to take you on a journey, basically going from that idea to the final product that we have now, with all the challenges and everything. So first of all, what I'm going to do is going to show you some slides of what the final solution of the how that looks like, and talk about some of the properties, and if there's anything you want to know more about, and we can discuss this after. So our test is so our company is called Llusern Scientific, which actually we are from Wales. We live in Cardiff, and the Welsh word for lamp is Llusern, and that's the Welsh mining lamp is Llusern basically. So we thought that was a cool name for the company. So our test is very easy. It's basically consists of a swab, a one tube assay, and a device, which is with a lamp reader. We go from swab to result in 30 minutes. It's point of care, it's affordable and portable, and it uses a non-invasive nostril swab basically, and with good sensitivity and specificity. So I will go into a little bit more detail about that. So of those three components, the first one is the nasal swab. It's a polypropylene swab, so basically the same material as a PCR tube. And we'll talk about this a little bit more in terms of regulation, but this is actually, it has to be a class 1 medical device because it's touching the body. It's basically like a plaster, for example, which has huge consequences in how we bringing this to the market. Like I said, it's very easy and non-invasive, which are important points in in the technology. The assay as well, and I know you guys are, of course, quite a few of you are molecular biology geeks, so I don't have much information about this here, but I'm happy to talk about this. It's based on LAMP. It's a direct solution, so we developed this so it can work without an RNA extraction. It detects two specific targets, the N and the E, and the primary set is based on Nathan Tanner's publication by NEB, right? So we worked really hard to fit this into one tube, so you can go directly from a swab into a tube and get the LAMP amplification. The device, actually, I've got it here next to me, as you do in your study. It's a simple LAMP reader. Okay, so it's keeping the tubes at the right temperature to perform the LAMP, and it is reading in real time the fluorescence. And of course, because that's what it does, is actually a platform technology, so you can use it for other applications. But what it has is an integrated algorithm, and it will look at the real-time LAMP profile and will tell you whether it's positive or negative by showing, I don't know if you can see it, like green or a red light in the on the top there. So for us, the idea was that for the user, it becomes really easy to to get the result. I don't know what we do with questions. There's a somebody's got a hand up.
Just is there a heated lid on it?
No, there's no heated lid. We had a look at this because it happens within 30 minutes. We basically
Don't have so
we
much
found out it
evaporation.
doesn't matter basically. So it's now CE marked. It can talk to an app as well that we've developed, and we've done a lot of field testing. It runs on 12 volt, so on the back of the car. So actually, we've been into hospitals and run our sampling there. And you could, so the whole thing, and again, it comes back to regulation. It is a standalone device. It's not dependent on software to make the decision whether something is positive or negative. Because if you do that, it's another bolt-on of the IVD regulation. But it does have an, I don't know if you can see, it has an USB port which you can connect to your laptop so you can see the LAMP profile as well. I will talk more about this in the platform capabilities of this device as well. So we call this the Lodestar DX reader device. So we spent a lot, and I mean really a lot of time in the clinic to get this as good as possible. And what we did our a lot of formal work in terms of analytical specificity and sensitivity, so we know what our limit of detection is and that it doesn't amplify other targets, other viruses. But in the clinic, we found that we have 100% sensitivity compared to RT-PCR and 98% specificity at point of care. And this is
importantly, Jeroen, just to say, this was on asymptomatic and mildly symptomatic individuals. These were not the ones that were very sick. So,
thank you. No, it's a really important point. We haven't made ourselves very easy, so we did not go into hospital and swapped like really ill people, and then we found that we could do a LAMP on people with a CT value less than 25. So these are like Emma said, asymptomatic, mildly symptomatic people. What you also can see is that, and this is something we've been struggling with in the clinic. I mean, it's basically the practicalities when you go in there and you ask clinicians to take a sample for you. You almost always have to store it. Sorry, is there somebody wants to say something? Oh. We found it in the clinic that clinicians, the easiest way is to take a swab, put it into a tube and store it, and then we test it. So we've done a lot of our data was based on that stored sample as well. But because our swab was designed to go directly into the LAMP reaction, it also means that we could not have any like viral transport medium in there. So obviously, over time, the RNA sample will get degraded. So when we look at our stored sample set, we see that our sensitivity drops. Okay, but of course, the whole point of this test is to be point of care, and luckily, when we do it truly point of care, the sensitivity goes back up to 100% in our case. I can talk about the clinical side as well. We will find out is that the nasal swab is much better than saliva. And I think that's because of inhibitory components in the saliva. So we find out, for example, the RNA got really quickly destroyed in saliva. So that's the reason why we switched to nasal swabs. But we've done a lot of work on that to get that data. So I just wanted to show you guys that, and I'm sure you've got questions about this, but maybe we can answer those at the end. What I want to do now is talk a little bit more about the innovation side of it, because we were a year ago, Emma and I, we were, and we still are, academics, and we basically wanted to help. And I think that's the same as you guys. We were sitting together, earlier than March actually, seeing the pandemic unfold, and we wanted to make an affordable point of care test, which was also not so dependent on the supply chain issues that were, especially at that point, were really, really bad. We wanted to have a quick result, and if it's possible to have it portable as well. So that's where the starting point for that we had last year. And to be honest, I mean, this is linked to something we can talk more about our urinary tract infection work and trying to limit the amount of use, the use of antibiotics, so have a better bacterial infection diagnostics. But anyway, so that's where we already been working on. So the technical challenges that we had straight away were basically we already made a prototype, a LAMP reader prototype, as you can see on this. I don't know if you can see my cursor, but which is a box that Ali and electronic engineering, other colleagues, they soldered together for less than £100 in components, which is a very rough fluorescent reader device. And we went in 4 months from this rough prototype that we already had before the pandemic into this, well, I think it's quite a slick machine, working together with design companies and electronic engineers. The other thing that we had to solve was the problem of the swab, because all the swabs that are there are actually absorbent, or most of them. And all the ones that have been, how do you call it? Well, they've been approved to take viral swabs are these cotton type swabs that you put in the viral media, etc. Because we wanted to make a direct LAMP reaction, we're working with 40, 50 microliters, and we didn't want to dip a cotton swab in there. So we decided to design our own swab. And this is probably the bit where we're the most naive with, because you think that's quite simple. We just made a little stick, but because it's in itself, it's a medical device. It was a whole new world of pain that we that we opened up there. But anyway, we started producing these swabs out of a 3D printer, and then we moved to polypropylene because we thought that the 3D printer, in the end, would not give enough capacity to produce them at scale. But of course, you have to partner with other companies that will make polypropylene molds and tooling and all that kind of manufacturing stuff. So it took us then 5 months to go from the first initial design to the finished polypropylene swab that you can see on the picture there.
You can't see it in the picture.
Can you not see the picture?
Oh, you can see the picture. Sorry, yeah, you can. Oh. Apologies.
I don't know. Yeah, it's a white screen, so maybe I was off the picture. But most of the time we spent the longest it took was to go from a first LAMP reaction that was based on an RNA extraction to the totally finalized direct LAMP solution that we had, and that took us 9 months of a lot of clinical tests. We had to. Well, first we had to prove basically that LAMP is working on RNA, which wasn't too bad. Very quickly we got that to work. We went through different primer sets, different iterations, and again, we didn't make ourselves very happy because we discarded some of the primer sets we thought were not sensitive enough. And I think although we lost time then in the beginning, I think we made the right choice there. So in and out of the clinic, so we had to decide where to swab, right? Saliva, nasal, or combined thing. All of that work had to be done, which population, and of course we were also dependent on how what the prevalence of the COVID-19 was. So in summer there was almost nothing around in Wales. So we couldn't do much of the clinical testing, but then of course we had a second wave and did a lot of work there.
But then just as that's why we've only got 62 point of care, because as we finalized everything and finally got logistics sorted in the hospital.
Oh. Did you guys lose Emma? Yeah. Oh, well, what Emma was saying is that the reason why we have a limited amount of point of care test samples is because we only finalized it in December, and we only had then, in terms of logistics, a month to test, and we'll come to the challenges as well that working in the clinical environment is difficult. Okay, so in terms of the challenges that we encountered in terms of innovation, were interesting as well for us. I mean, for us, it has been an amazing journey. So we've learned so much. We were, and maybe you still are, naive academics in that sense. But I think that's good, actually, because we were just wanted to help, and you need that drive to make it happen. But the first challenge that we have is that, because we are employed by university, the IP is owned by the university automatically. So whatever we do, whatever we invent, the university will say, well, we own this. So that is a discussion we had to have. And I have to say that the university has also been very good. They've taken us away from our teaching commitments, and they say, okay, you guys, you're just going to focus on the testing. So there's definitely a huge benefit there as well. But then there is, at least in Europe and in the UK, of course, where we wanted to help, we had the in vitro diagnostic regulatory framework. And it means that somebody or something has to be legally responsible for the test, right? So when you can't just sell a test and then somebody does it, and then at least in the UK, somebody needs to take responsibility. The university doesn't want and won't be liable, so they wouldn't take that risk. The only other option was for the NHS, and I think it's a UK specific thing. The NHS is by law exempt from liability. So we could give them LAMP test and they could self-validate it, and then that would be fine. But even them, if they would like to buy kits and finalized products from manufacturers. So basically we had two options. We either were going to have to license it out to another company, because somebody has to be responsible, or we had to form our own spin-out company. And we'll get to the ethical considerations. We felt that if we spin out our own company, at least we are in charge, so we can decide what to do with it. And we felt that there was less of a chance when we would license it out. Also, the licensing option was only there, very early on, and we felt we weren't ready for that either. So the product wasn't there yet. The other challenge we had was funding. Of course, all this stuff takes time and costs money, obviously. So we spend a lot of money on enzymes, and so we got good internal funding from the university. So they've been really good. So they can say, okay, here's a bag of money, you start working on it. Don't worry about funding straight away. But then our local government, the Welsh government, gave us funding as well. But because that's public money and we had to spin out a company, because of the funding rules, Welsh government, for example, cannot fund the company directly, because that would mean state aid, and there are rules for that, so they can't do it. So as a company, we were then forced to have private investment, which is not necessarily a bad thing, but it takes you onto the path of a private company and investment and all the challenges there. The other challenge that we had was there was a huge pressure on us in terms of time, because from ourselves, of course, because we wanted to help as quickly as possible. But we've been in the media, and from vice chancellors to Welsh government, everyone's kind of breathing down on their neck to get it done. So which was difficult. And then the clinical access is very important for our work. So the partners that we formed, so we were lucky, but we also invested a lot of energy in forming partnership with our local National Health Service boards, so we can get access to, and not everything was perfect. But it's a very large bureaucratic organization. The National Health Service, I think, is the second biggest employer or third, I think, maybe in the world, after the Chinese Army and McDonald's. So it is a huge organization. So, and then finally, the ethics. In the end, we still are academics. We want to make sure that what we're doing, what we're thinking, what we invent in the lab will have a positive impact on society. And that's what we're trying to keep moving forward. So this is my last slide, and well, we're not out of COVID yet, obviously, but what's next for us is we're bringing the COVID test to market, truly to market, and then work on our LAMP reader device and use it as a platform technology. And our first thing we're working on is urinary tract infections. And in fact, the people in the lab, we are working on UTIs at the moment because scientifically the COVID work is done. And what we also are very interested in is to find global partners to reach this impact we're looking for. So that's the presentation. And if there are any questions or notes, whatever, then we're very happy to talk about this. Thank you.
Thank you so much, Jeroen. And yeah, the floor is open for question. I think it was quite interesting how, yeah, I think Guy has had his hand up for a long while, so maybe I should just let Guy go ahead. Okay, go for it, Guy.
You muted, huh?
Yeah, I have. So there's a bunch of questions. Can you say a little bit about sort of the price of the machine, the reaction, or a test, or do you sell it like 8 at a time or 1 test per?
Yeah.
We also had to talk like a week ago about all the whole, so right, we're academics, we're really bad at like sales and things like that. That's a whole other thing, right? And then there's a bunch of other questions, but
Well, so first of all, the machine we wanted to keep as affordable as possible, and I guess it depends on how many we make. So at the moment we have a sales price of 800. But if the amount of machines that we built, it could significantly go lower.
Yeah, and we're looking as well to, there's some people, like we've had interest from cruise liners and airports, and we're kind of happy to charge them full price, but we're also very interested in a kind of cost plus model. If there was enough sales, and if people wanted to use them, depending on the situation, if it was kind of in countries like, well, for example, in India, then, you wouldn't necessarily want to make a penny out of that. So the cost price of those machines will come down significantly if we get enough of them, if we get a big enough bulk order. And then per test, again, the final price isn't we don't know exactly, but they come in strips of 8, and then you also get a positive control as well. We're looking to sell them in batches of basically 96. So we don't want to sell any less than that to one person. So it'd be like 96 plus your positives. And that works out at, it's about £8 or £9 per test, but that includes your positive control and your swabs. So there's literally no extra costs on that. And again, I think we could significantly come down on that if we had large enough orders. So yeah. And
then it works on fluorescence of only sort of green or something like that.
That's right. It's based on green fluorescent. So in terms of technology, it's a blue light with a filter
with a dye, not something like sequence specific or something.
That's right, with a dye,
an intercalating dye.
Yeah.
And the volume of the reaction, you said like 40 or 50?
It's so it can go as low as 30 microliters. We haven't really tested going lower, but of course at one point you could. It's when you look through the tube, it's not enough to work, but it will work with more as well.
Ours is based on 40.
Yeah,
and it's just PCR tubes.
It comes with everything already in the tube, so you need a cold chain for the whole thing, and you just put the swab in that, stir it, and take it out.
That's right.
Literally that, yeah. And one thing we're looking into is the idea of freeze drying the components. I've no idea. That's just a new conversation we've had with someone. But at the moment, yeah, we do. It does need cold chain storage. So.
And it's just direct. There's nothing like, you don't do anything sort of fancy or hidden to open the virions or something.
Nope.
just from the nasal swab, and it's not like textured the swab or anything to try to catch more or anything. It's just sort of smooth polypropylene.
It's
Sort
not
of
smooth. It is.
like. I mean, I buy these like little, right, like polypropylene pestles, so it looks
Oh
very
yeah,
similar.
yeah, I remember those. Yeah, no, it is structured, the swab, to collect a bit more.
Okay.
Yeah, so there is yeah, it's like a ribbed structure.
But then, yeah, that's it. And I think there was someone else who'd asked during the talk, is there not a problem with nosebleeds? And I wondered whether you had one to demonstrate your own, but it is literally, I mean, the way that because we've been there in the testing centers, actually, you know, going up and doing supervised self-swabbing of patients. And we've done probably close to about 300, 400 samples in total and not had a single person have a bleed, because it is literally designed to swab gently but firmly around the edge of your nostril. And then you just literally take that and dip it directly into the reaction. And there's a bit of, it works better if you double dip. So in, give a swirl, up, in again, swirl. But that's how we've got our clinical data, just using that. No DNA extraction, no sample processing, nothing.
I had one here, but I think it dropped on the floor.
Don't worry. It's basically like Guy's pestle up your nose. Just
And then the last thing, right? So there's last one. So there's there's a medical device for the thing, for the
it's called a medical device.
Yeah, but that has to go through some sort of regulation. Also, the machine has to go through some sort of regulation, and then also the test itself, right?
So the device has been CE marked for electrical safety. That we had to make sure that had all its essential requirements, that it wasn't going to blow up. So that's done. And then, yeah, the swab itself is a class 1 medical device. So that has its own CE marking. And then the whole thing, so the swab reader and device is, I don't know, it's not mine.
Not mine.
The whole thing is then, well, we say it's CE marked. We are literally going through the contents for that one tomorrow to kind of finalize it and sign it off, but that's all done as well. So,
and it's all going to get harder in like 6 months when the regulations change in all of Europe, right?
Yeah, I think we've got up to about 12 months, but we've paid for a decent QMS software that's going to help us, like they're kind of green light guru, so they're going to help us through that process as well and make sure we're in place, ready for the change. And we're working with a IVD consultant as well, so we know that we've got that lingering in the background.
Yeah, so it was one extra. It wasn't one extra challenge, but everything we do, we take that into account, basically, that we don't have to start again.
Can you say a few more words about like getting the machine CE? What does that mean? What do you have to go through?
So we so first of all, we had to design like a prototype design company helping us, which was funded by government together with us. So we basically talked to them and said, well, this is the spec, this is our prototype, can you translate it into a user friendly device? So they've done that, but while they were designing that, they wrote everything down. All their design choices had to be written down, because that is, in the end, it's going to be important. Then they made a pre-production prototype, which underwent a pre-compliance test. So basically, for example, they were measuring whether it wasn't giving out too much radiation. So when you switch it on, that your Wi-Fi in your house doesn't go down, for example. And the other way around, that if they blast it with some static electricity, it doesn't break. So there were some simple tests there, and then also whether the temperature was stable. Then we had to make a manufacturing ready device. So one of the largest costs is actually the plastic, the molding, which is really annoying. I mean, now it doesn't cost anything anymore, but to get there, it costs you tens of thousands of pounds just to get that. But you need it for the final testing, which is the C compliance testing. And again, that is two things: is radiation and immunity. So basically, that it doesn't give out radiation, but also it when there is some radio, I mean, it's a lot of frequencies if it doesn't stop the machine. And then they do drop tests, they try to set it on fire, and all that kind of stuff. And that's expensive. I think we paid £20,000 just to get that report. Officially, it's a self-declaration. So as a company, we sign a document, say this thing is safe. But then, of course, if somebody gets electrocuted, then we haven't done everything, what we could do to make it safe. So you have to run through these tests to make that claim. And to be honest, we got a lot of help from that design company. So they were specialized in taking an idea from an academic, whatever, and then to manufacturing. So they don't manufacture. That's somebody else again. But they're helping with the link between the prototype and the manufacturing. So hopefully that's a little bit clear. But it's quite a journey, to be honest.
Okay, I think Catherine has had her hand up for a while. Please, Guy.
I have quite some questions, so probably Ali could go first because he also had some.
Okay. Yeah, I was curious, two things. One of them is what kind of limit of detection do you have without an extraction? Does that matter in the Welsh regulatory context when they're comparing it with other tests? And also, if you have any kind of like endogenous human control, and if that matters in the regulatory context.
So we did a few things to, first of all, we did like RNA extractions and then did our limit of detection that way. So the amount of RNA molecules we could detect. But we also compared it to what we call is Public Health Wales. So it's the NHS in Wales, let's say. They had a reference panel. So all the machines in hospitals that are doing the COVID-19 testing get that panel, so they internally validate it. So we're basically comparing CT values of those machines to our detection method, and which is not ideal because they're actually extracted, right? So at that point, we have a limit of detection of CT value of 35, roughly. But of course, that's not ideal because that's not what we do. We don't do an RNA extraction. So in the end, we had to go into the clinic and work on real life samples because that's the only thing that actually matters. In terms of regulation, it's
not essential criteria, it's a desirable. So
yep.
We don't have an endogenous human control. What we have shown is that it's very difficult to get the swabbing, if you do it according to our instructions, because there's no storage issues and transport issues. If you're doing it truly at point of care, then as long as you've done the swab in the correct way, which you can get trained on how to do, then there should be no issue because there's no transport or storage or anything for it to go wrong. So while ideally, yes, we would have that for every person. And initially we did, when we first did the RNA extractions, we were running a control for all of those as well. But what we found with the swabs, and we even started, when we started using the swabs, we were doing an actin control as well. But we found that we never, ever got a negative for when we did it directly. So then we basically trust the process now. So you have, every run has 6 samples and a negative and a positive control. So you know that your runs are working, you know that your reactions are negative, you know that your positive's working, but no, it's desirable rather than essential for this kind of test. And again, just take the lateral flows, I guess, as an example of that.
And also, what's also important when you go through regulations is the classification, so who the user is. So the self-test is the hardest one because that's basically everyone should be able to do it. We haven't gone through that because that's, it's too difficult. What we are claiming for is professional use. So somebody has to be trained to do it. It's very simple. It's literally just doing a swab and put it in a tube and in there. But there should be somebody there supervising the swabbing. So you kind of, that helps.
Okay, maybe Catherine now.
Yeah, thanks a lot. The Q&A and the talk is very insightful for us, so thank you for your time and efforts. I have a bunch of questions myself. So my first one is, do you produce your enzymes yourself? So is it in-house do you use in-house produced enzymes in your assay?
No, we buy them from NEB.
Mm-hmm. So follow up on this, do you have any downstream IP licensing for your product?
So we've patented the whole process basically, and I think it's
Upstream, sorry, yeah.
Are you paying
We
NEB
have
and
ICAN.
ICAN? Yeah.
Are you paying any
NEB
license fees to any other actor?
yes. Well, as you know, the LAMP is covered by patents, which actually run out in this autumn in Europe, at least. I don't know where the other.
But NEB have put us in contact with ICAN, and we've been in touch. They know about us, and we've got an agreement with them. We don't have to, because we're not commercially active yet, we're not trading, then we haven't yet, but we do have an agreement with them to just pay a license to them, and we have an agreement from NEB as well. So
in case you have some profit at some point, but not right now, or
yeah, that's the idea with ICAN. I think as soon as we make profit, then they want the money. As soon as we make sales, sorry, they want the money. NEB, I believe, they've just waived their non-commercial, so they've just letting us use it.
The suppliers, basically. So that's
they'll be our suppliers.
Yeah.
They make money from just selling it. Yeah.
Exactly.
Exactly.
Yeah, no, that's true. And for us, to be honest, it was one, and I know you guys are much more into the homebrew stuff, but for us at that point, it was one thing not to worry about.
Yeah, it's a big thing.
yeah, exactly.
Yeah. So some more questions on this. So where do you produce your tests? Do you use your academic laboratory? And how do you take care of the quality management specifically, if you are able to talk about that?
That's a good question.
Good question. And that was a real challenge for us and a real eye-opener. I think we were very naive going into this, and we didn't realize quite how little we could do from our academic lab. So obviously for all the R&D side of things, then we were using our own, we were working in an academic lab. But for our validation, then we've been working with us. We've basically got supply. Sorry, my little one's just come home from school. Hello, I'll be back in a minute. Go on, Jeroen, do you want to take it? This is Jess. She's just come home from school.
How was school?
How was school, Jess? You were on a trip today, weren't you? You went den building outside. Jay, you take over. I'll be back.
Yeah, sure. So basically, we in a way we are almost like a virtual company, because we have a supplier for the assays. So we're working together with people that are ISO accredited, so they've got the facilities to make the assays. We have the same for the swab, and then the same for the device. But in the end, we are responsible, so we have to quality assure all, everything, which is a huge thing actually.
So you do like a basic, like a final quality testing or assurance testing of every batch, or?
That's right. Yeah. I mean, we have to write formal protocols, how we're going to do that, and I mean, they have their own internal controls as well. Before, from their suppliers, when they get primers in or enzymes, they first quality check that, then they put it together, they check it, then send it to us, we check it, and that's the same for the device and the same for the swab. And
we've picked our suppliers carefully, haven't we? I mean, we picked them on the basis of experience in this area because we're not experienced, and so our quality controls can be simpler because theirs are so robust. But we still now have standard operating procedures for our quality checks and everything. So we've worked really hard. That was a big challenge to kind of think about things from that perspective.
And also we kept them local. We tried to. So they are actually Welsh companies. And I you know, it works. It's just easier because then we, you know, we can just go to them. And yeah.
Yeah, so you collect all the quality control data upstream and collect it as well. So you have everything in one place then.
Yeah, and we've been working with an excellent consultant. Again, we are lucky to have the funding to kind of pay someone who has experienced, you know, she used to do, well, she still does audits for the MHRA, so she knows about IVD and she knows about all the quality management systems that you need in place. And she's been brilliant at helping us pick out what we do and don't need, because at the end of the day, as she says, we are fairly low risk. We're not like a, you know, we're not injecting people with anything, and it's been tricky for us to work out what we do and don't need as a virtual company, basically, because we're not planning on bringing our manufacturing in-house. We don't want to do that. And she's been kind of guiding us through that process, and that's been invaluable.
You definitely need help with that.
Yeah.
But all the manufacturing is done in Wales of all the different parts.
Except, of course, I mean, NEB, of course.
Yeah, they make it in Boston, but okay.
Yeah. Yeah.
Okay, can we please move to Jen? Sorry, we could, because of time, we could come back to more questions, but just to give Jen, and I see Fernan also, just so they have the chance to ask their questions.
Yes, thanks for the presentation. I have a question that how long does it actually take from the start to finish of this like CE certification of the procedure? Like, is it like 1 month, 10 days, 1 year, or? So
a lot of companies will take 2 to 4 years to bring something to market. Actually.
That's from proof of concept, isn't it? I mean, it depends when you say the CE marking process, where you're starting from, I guess, is the key to that. But
I think so. Sorry, Emma.
Go on, Jay. Go on, Jeroen.
As soon as you start to think about things when you're designing, that becomes part of your technical file, and that's part of your. Well, I think in the US you call that MDR. You know, that becomes part of the process. So you need to document. You need to document that. So I think the more formal, the clinical test was a huge chunk, wasn't it? And that took us months to get that.
That really depends on access. So again, our target was 150 positives, and we actually got nowhere near that. And again, we're taking advice to say, actually, you know, rather than waiting for a third wave to hit and then going, oh, we're still working on getting the clinical data, what we're committing to is post-market surveillance. So we're going to carry on with our clinical data, but we're going to get it onto the market so it's ready in case there is a third wave, so it can actually be used. And I think, you know, if you've got access to that clinical data and you've got lots of people with positives, you could collect that really quickly, but it is a huge piece of work to bring together that technical file. That has been, I think we definitely underestimated that. I don't think it would be possible, however ready you were, to do that in 1 month, because you have to have so much in place and there's so much documentation of everything that you're doing. And as Jeroen says, it's even things like we have to make a note now to say, you know, you're supposed to validate your choice of suppliers formally before you choose them. We didn't do that. We just went, oh, great, there's a local Welsh company, we'll use them. They've got the right experience. And now in our technical file, we're kind of having to document that and say, well, we didn't do it formally because, you know, we were early, and next time we will do. And it's all thinking like that is so different from what we're used to. I would say to do it in a year in the way that we've done it has been pretty challenging and pretty difficult, to be honest. But you're talking that kind of timescale, really, depending on where you are in the process.
I mean, like one like clarification, like if I would like notify someone that I have like somehow all the data, then how long does it take actually that they would say that it's fine?
Well, they don't say it because you self-certify. If you are just an IVD and you're not for one of the high risk diseases, then you can self-certify. So they can then, in the UK, the MHRA then can ask for your technical file and your data at any time, and you have 2 weeks to provide it to them. So to put the technical file together, oh, what do you reckon? I'd say, I mean, I don't know how long, it depends, but I'd say roughly 3 to 6 months, I would imagine, if you had all the data that you needed just to pull it together and make sure it's all, yeah, I hope that's kind of a rough estimate, but it's a difficult question to answer.
Yeah, and it sort of depends on how many things are completely new as well. So we had to write two, so it's for the swab and the whole test. But if you would validate something on an existing platform and existing swabs, maybe it's a little bit easier.
I think it would definitely be easiest for us now we've been through the process once,
Yeah,
then
yeah.
we would definitely, you know, and happy to help other people if people are trying to do what we can to help. But yeah, it's been quite a task.
Okay, great, thanks.
Okay,
Well-
Fernand, sorry, I was looking for my mute. Fernand, do you want to go for?
Yes, thank you. Well, thank you all for the great talk and sharing all this information with us. I have 2 questions. One is, you mentioned that the university kind of like provided like a protective time zone for you to shield you from the academic work. Can you comment a little bit of that? How much time this has taken from your normal day academic work? And the second is related to the IP. You said the university, whatever you do in the university, they own the IP. Is that the full 100% of everything that you do is shared with them, or is only them? And in what part, the hardware? Because you mentioned that the hardware was you had help from the government. I ask this because if you decide, for example, to release design files for the hardware, for example, where will you see the bigger barrier there? Who will say, no, you cannot do this because we own the IP, basically?
So so the first question is basically, well, we've taken off, well, I don't know, I was only teaching 20%, I think. So they appointed someone else to cover for me and Emma in terms of teaching. But it hasn't been normal weeks for us in the last year. So we're working too much, to be honest, because we still have our academic duties. You know, we've got exams next week. So it's been really tough. And although they've been quite good in trying to protect us, but the reality is that still stuff is ongoing, you know, and we still have final year project students and, you know, these things. But I think they've been as good as they could have been. In terms of IP, so when we signed a contract with the university as a lecturer, it says that, you know, all the output is owned by the university. We have rights, as we have inventor rights and copyright, but in general, the IP is owned by the university. So what we've done now with it's basically the university are shareholders of the company, and so they're basically putting their IP into the company, which is a really how do you call it? That's like a normal procedure. Does that kind of does that help? So
Are you saying what would they say if we say, oh, we want to, you know, open source some of this? Are they going to get difficult about it? I think if we just wanted to open source everything, then yes, I think they would, because ultimately I think they see it as a commercial venture as well. But I think if we could come up with a viable business model where we did a little bit of everything, I don't think they would risk the reputational damage. And they are, after all, an academic institution still. So
yeah, they're not for profit.
You know, if we can put into their next research excellence assessment that we, you know, did something that had big impact somewhere, then that's really, really important to them as well. So I think we'd have to be sensible about it, but I think if we get it right and sell it in the right way to them, I think they'll be okay with it.
Yeah, and in the end, the IP is going to be, if the company is successful, the IP is going to be transferred into a company, and that's like a normal procedure as well often. So they don't keep it forever, because that's not in their interest.
Oh, okay, Guy. And And at this point, I think the first person who can speak, because most people have gotten the chance. So at this point, if you have the loudest voice, jump in, please. Guy.
I can wait for a second if somebody else wants to go. But
Okay.
I think there was a little bit. Go, Kathleen.
I just had a question that was bugging me as well. So about the IP situation, did your employer, actually your university, was insisting on protecting your invention at some point, because you are using their resources as well, so they have like some say in this, right?
Well, they own it, right? It's up to them what.
Yeah, and they are interested, and they are going down the route of filing a patent, but that doesn't, that's still, again, that's why we kind of wanted to talk to people and learn more about how we can, as Jeroen mentioned, keep to what our initial driver was, and make sure that we don't want to, we think we've made something that's useful and cool, and we want to share it. So I think it's balancing that with the interests of the university and the fact that they're patenting some of it.
For us, it's also, sorry, Catherine.
I know
for
that
us
was
to,
no. No, okay. Go on. Sorry, Jeroen.
So for us, it was to be able to keep control as inventors is important as well. Because otherwise it could just go away. I mean, I don't mean control in a negative sense, but at least not somebody else is taking control and then we'll shut it all down, basically. Does that make sense?
You mean that you would be worried that someone else would take the invention and IP it in front of your eyes, or?
Yeah, and it's hard because it's also, I mean, the reality is, of course, you need money, right, to do this. Yes. I mean, at least we in the in the UK, so you can't attract, at least in the British situation, and I think in Europe as well, it's very hard to attract money if there's not some kind of guarantee for the investor.
People are obsessed with IP in this country. Absolutely.
Yeah, I know.
We had a really good talk with Fernan about this a couple of weeks ago.
Yeah, I know. Yeah.
Yeah.
Oh.
Somebody is gone again. Yeah.
She became glacial.
Yeah. So.
IP model.
Okay, that sounds interesting, I guess.
Yeah. No, it is a challenge, and it's yeah.
Mm-hmm. Thanks.
Okay. Emma, we lost you a bit.
I know, I give up, honestly. My internet's being rubbish today. You carry on. I'll chip in when I can.
Okay. Yes, Guy.
Can I ask two little tiny things? I think what Ali was asking before, and also Rachel's asking me, do you have any, because for an American EUA, you need a limit of detection. You just say we can catch 20 out of 20 of 20 copies or something. But you guys don't really need anything like that, or didn't really do it carefully somehow, or?
We have done it, but the only way we can do that is we did it on unextracted viral particles, and Jeroen, you do it actually, because I can't, I'm going to lose myself again. I'm going to lose internet.
Like you did it on inactivated particles and like synthetic RNA or something.
Yeah, we did it.
That's
right.
Yeah.
Yeah. And it's, I mean, what was it? It was about 400 per mil or something, was it? Or was it? I can't remember.
No, it's 40 per reaction.
40 per reaction.
One per.
Yeah.
Okay. And then we all know, like, the big problem with LAMP is, right, like, false positives, and if somebody by accident opens the tubes, then like we're in a special kind of hell. So what do you do against that, if at all?
So a couple of things. I mean, we were really, really worried about that when we went into the clinic. We thought that everything would be positive, but it wasn't. So that's really reassuring. However sensitive it is, we don't appear to get lots of false positives. I mean, we can
Because
detect.
it's you doing the test in the end, right? Like on these clinical samples. But the question is when somebody else is doing it suddenly, or has it? Yeah.
Yeah, of course we say don't ever open the tubes. I mean, obviously, no, yeah, of course that is a huge problem. In the production is a problem. We haven't been too bad. We have had a couple of contamination issues early in summer last year, but we've been basically paranoid, about this. But we haven't had any contamination in the field actually, and we've been at this. We've done the testing at the same place over and over again as well.
Yeah, we're just careful, and we make that.
But it's you doing it in the end, or you train other people to do it.
Oh no,
we're doing the actual tests. Other
Yeah.
people have been taking the swabs for us,
Yeah.
but yeah, we have been running the tests. But we haven't been, we've been opening the tubes and dipping the swab at point of care in a clinical room. We've done it in a lab. We've done it in the boot of a car. So we've done it in places where it's not like a sterile lab environment. But yeah, I take your point. And when other people use it, then, I mean, we've just made as clear as we can how important it is not to open those tubes once they're run. And I guess the negative control is good for that. And people could even open the negative and shut it in the environment if they want to make sure that their environment is clean. So we have got ways of detecting environmental contamination, but yeah, it is something that people have to be careful to.
Yeah, I mean, we've also run operator controls so that we swab ourselves or somebody else doing it to make sure that's clean. But in the end, Guy, of course, somebody else is going to do it. I mean, we've been doing that ourselves for the validation and a research assistant in the lab. But yeah, of course, we are not going to provide that service. So the idea is that the box is going to go somewhere and people will do it themselves.
And then last question is, how do you see it? Like right now I'm in Paris and every corner has an antigenic test, which that's 5 minutes and whatever, the same price or cheaper even, or like, so how do you see, and there's a qPCR you get in 20. So how do you see yourself in the market, or in which places, something like that, like, or comparatively, or?
Yeah, I still think what we have doesn't yet exist, again, at least in the UK. Yes, okay, you have all the lateral flows that are everywhere, but people are not confident in those and they're not used as gateway tests. So I see ours, for example, when things do open up, but you have a vulnerable group of people, or you might have traveling corridors where you really want to make sure that your negatives are true negatives, then I think our test is great for that. And I think at scale, we can come down to a comparative price. And so then I think at the moment, the government bought millions and millions of these things. So everyone's using them for free. Once that runs out, I think people will start looking at quality again, and they'll think, well, if ours is just as easy to use and easier to use and just as a comparable price, then I think that's where it will be of interest, and where people can't social distance and they are becoming close together, then that's where we've had the interest.
And a place where you don't need such an invasive test. That's another issue.
Yeah, we've had quite a lot of user feedback about the actual swab and how much people like it, because people that we spoke to when we were doing, because we did staff testing, so hospital staff were just coming in for random tests. They were all asymptomatic, and we picked out the same person with COVID as the official test. So that was really good data. But it was one lady was saying, she works with children with learning disabilities,
kids, especially the kids.
Yeah, and elderly people in care homes as well. The same thing. To go for them for a throat swab, or even worse, a nasopharyngeal, that's too invasive. So I think there's that option as well, is just this ease of, a lot of kids from secondary schools here have got the lateral flows, but they're expected to do the nasopharyngeal, and nobody's doing it properly because they hate it so much. So I think what we have is still, because it's simple to use, but it's molecular accuracy, then I still think that there will be a need for that, especially at the moment we're all locked down. Once that eases and people start moving around, then I think there'll be a need for an accurate gateway screening test.
And then a last thing, a comment you asked, like what other things you might want to put it on. So we had a call on this global LAMP community call that there was people who were willing to help a lot with tuberculosis. Supposedly that's a really big problem and they're willing to help. with getting the clinical samples, getting through all the regulators, connecting to all the people who need. So if you want to think about that.
Yeah, that sounds great.
Exciting.
Yeah.
Yeah.
That's really good.
Lisa?
Yeah, I had a question somewhat related to what Guy said about the final price of the test. And it's regarding the use of commercial enzymes. So you were saying that you use commercial enzymes and then you need a cold chain for them. So I was wondering how much of the total price of your solution relies on, depending on the cold chain and the commercial enzymes, and whether that will change in terms to make the price more efficient in the future once you go into the market with this.
So it's the price of the enzymes is significant. It depends. It all depends on scale, right? I mean, this is something we can't really discuss because we're in discussion with NEB. But basically the two things, right? So you've got your price per reaction, where you can look at list prices for for BST polymerase, for example, and and RT. So you see they will be expensive. The other half roughly is labor, but of course that will be massively reduced when we scale up. But the price of the enzymes is significant, so that can go down.
But I mean,
go ahead.
Well, I was just thinking, because we've got the three parts to our test, we could work with someone, that the innovation is not in us making the reaction mixture. That's just what NEB published anyway. So anybody could use their own enzymes. We just, in the NHS, they don't want to. They want a one tube solution that's ready to go. But if someone wanted to use it in a different way and make their own reaction mixture, but we could give the device and the probes, then, maybe there's that kind of solution. Yeah,
but then we, as Llusern, then it's not our diagnostic test. Basically, we'll just be then suppliers of a LAMP reader and a swab, and then it's up to
someone else has to validate. Yeah.
Right, but then the cold chain is something that you have to deal with,
if it's freeze dried and then there's no cold chain, and you make your own test with your own enzymes and your own primers.
Yeah.
And you just take from them the swab in the machine, but then there's another step of adding a liquid to.
Yeah.
Thank you. And the second you add a pipetting step, then it's complicated tests. Till then, it's simple. If you add it,
I think that's it. And there's a whole range of end users, and there's definitely a big part of them that don't want anything like that. They don't even want to use a pipette. They literally want it all ready to go, and that's fine. So we're catering for that, but. That's not to say potentially in the future, if we wanted to work with global partners, who we would just need to prove equivalence potentially. So if someone was making their own reaction tubes, we had to do that when we were originally producing them in our lab, and then when they went to the manufacturer, we had to prove equivalence, which we did analytically and clinically. And we could do something similar if there was a cheaper solution for people where they were making their own reaction tubes. That's a potential way of going forward. Working with partners in other countries. So
right, so basically just like profiting on using the device instead of using the whole pack with the enzymes and everything, just on the device that you design, something like that.
Yeah, so the certification we have as an IVD, so if we were to say, right, this is a CE marked IVD, we'd have to sell the whole thing. But we could sell the device separately for someone else to validate, or we could, as a longer term thing, we could say, okay, well, basically we're just changing the supplier of our molecular reaction. That's all we're doing. We're not changing the reaction. We're just saying, okay, rather than NEB enzymes with our local our local supplier making them, we'll work with, X person somewhere else in the world who can just do the same thing, put together the molecular reaction, and then we'd have to validate that was the same. But then we could say, okay, well, we now say we will take responsibility for this as an IVD, and this is an alternative supplier. That's definitely a possibility.
Okay.
But this will change next year, right? The self-certification.
Yeah.
So at least in the European Union.
That's true. Yeah.
Yeah.
And I don't know enough about that process other than we'll need someone in to audit it all and to kind of approve it all.
That's 2 years
Yeah.
from now, isn't it? I think.
We have
3
to
years?
start it. I can't remember the final date of it. I think the final date is 2023, isn't it? But we have to be
May
ready
20,
to.
yeah.
Okay. Oh, and I
um,
remembered it wrong.
It's
It
about a
starts
year's time we
before.
have to start. Yeah.
Mhm.
Preparing for it. So yeah, I don't know
Okay.
how that will affect things.
So your initiative is, or you're thinking of it as on a long scale already. Then probably you should also, yeah, dig into other pathogens that are most probably a big problem in rural areas, or not just in Europe.
Yeah.
But yeah, there is a lot of work,
Definitely,
and I think
that-
there you can help a lot there.
Yeah, definitely. There's so many applications, and what we'd love to do is help out with people like yourselves and other people who are, you know, who can see the potential in LAMP and this kind of diagnostics, but haven't had the luck that we've had to manage to get over this first hurdle. Yeah, neglected diseases, anything. It's basically what we used to read about with LAMP is, oh, you know, it's great as a diagnostic, you can put it in a water bath, but that's never going to really be approved. So I think what ours is doing is taking that next step and saying, okay, well, we've got something that is approved, at least in the UK at the moment, for as an IVD, and so it's a step up a water bath and looking to see if you've got a color change. In my opinion, it's a bit more robust than that. We can approve other things. We've gone through this process now. We've learned so much in the last 12 months. We'd be happy to, we feel like there's a huge bottleneck of academic ideas and idealism that doesn't get out there into the real world because of this, you know, this disconnect. It's not a skill set many of us have. So if we can help other people, you know, and work with the people to say, okay, well, let's take this a step further and make this into something that you can truly use as a diagnostic, then that would be an absolute success story for us, because that's why we started on this journey in the first place. So looking for partners,
thank
really.
you so much, really. This will be a huge help for a lot of people. I'm very sure about that.
Oh, well, that's amazing. Really, that makes, yeah, that's why we did it. And yeah, it's exciting so it'd be lovely to talk to people about, you know, potential applications and where people are and what they're working on and their ideas and experiences. I think that would be really, really exciting.
Cool. It is quite past the hour, and thank you so much to Jeroen and Emma for wonderful talks. Thank you everyone for wonderful questions. Please don't forget we have the forum. This recording is going to be on YouTube, so if you wanted to go through and refresh and think more, and if you want to contact Emma or Jeroen, you could actually, either me or Fernand could let you, I don't know if yeah, I don't know about putting their email out there publicly, but
oh, that's
yeah,
fine. We don't mind.
Oh, okay, sure. Then I can actually put that in when I'm making a follow-up post on the forum. I could put their contact details there, so you could please feel free to reach out. And yeah. Oh, Jeroen already did his email address.
I mean, you can even go to the Llusern website, and there's a info@llusern.co.uk. We pick it up from there, so we're not hidden away so well yet.
Absolutely.
There you go. Mine's just Emma@Llusern, so it's same thing. So yeah, do contact us if you've got any ideas.
Cool. So do I say thank you? Thank you very much, Emma. Thank you very much, Jeroen. Thank you, everyone. And
thanks for your time and for everyone's questions. That was really good.
Yeah. Okay, so we will be back in 2 weeks and with another edition of this talk series, and you have a lovely rest of your week. Bye.
Bye. You too, Deborah. Thank you for all your
Bye-bye.
work. Bye.
Thank you. Bye.
Thanks.